Good afternoon, ladies and gentlemen. Um, Presenting this talk uh, as part of the activities lined up by St. Emmanuel Hospital to mark 50 years of service. I'm Dr. Adebayo, I'm a cardiologist, and I'll be talking about understanding heart failure and prevention of heart failure. It's very essential we talk about heart failure and the way to prevent it, because it's a very common condition. So I start by saying that heart failure is a clinical syndrome consisting of cardinal symptoms accompanied by signs due to structural and or functional abnormalities of the heart that results in elevated intracardiac pressure or inadequate cardiac output at rest and or exercise. To explain that is to say that essential components of heart failure is actually things that the clinician can recognize without having to do any test at all. That's why we say it's a clinical syndrome. Usually due to complaints and then some signs that the medical practitioner can pick up by examining the individual that is affected. And usually the underlying abnormality is either there's a structural problem with the heart or there is a functional abnormality. And then the end of that is that the heart is unable to pump blood sufficient to meet the metabolic needs of the body. Or then in an attempt to do that, it has to do it at the cost of an elevated intracardiac pressure. Of course, that gives symptoms. That is the definition of heart failure. When we look at how big is the problem of heart failure, it is a big problem indeed, because you have people in their millions in Europe, 6 million people, in the US, in the range of 5 million people, more than 2.4 million people in Japan, and it is estimated that new cases up to 1 million is diagnosed annually. So it's a very serious problem indeed. And when we go into population, one may wonder, where is Africa here? The problem, I'll show us the data later where I will give more explanation. When we look at the population, the prevalence of heart failure is estimated to be between 3 to 20 cases per thousand. But as people grow older, the prevalence of heart failure increases, so that in those that are more than 65 years of age, you have about 100 cases in 1,000. So it is actually known as a case of the older people or the older population in the United States and in the Western world generally. But of course, as I'll also show you from one of our data, local data, you find that this is not the case in Africa, and particularly in Nigeria, in which case you have the peak incidence occurring in the people in their late 40s and then in their 50s, which ought to be the peak of the productive population. In the general population, you have about 1 to 3% of people who are affected. And then, of course, because it's supposed to be a disease of the elderly, it rises up to 1 to 10%, the very elderly. And the overall incidence is about 0.1 to 0.2%. And then a lot of medical admissions and cardiac unit admissions are due to heart failure. In sub-Saharan Africa, between 10% to about 43% of medical admissions may be due to heart failure, depending on where. This is a very busy slide and is data across Africa. What I just want to highlight from this slide, if you look at the column that's labeled HHD, so that's talking about heart failure that's related to hypertension, which is actually the predominant cause in our environment. If you look at about the middle of the slide, you'll find about 78.5%. So if you look at other data from Nigeria, like the fourth answer, 209, you find about up close to 50%. And then in Abuja, you have about 61%. So you find that this is ranging between 50 to 80% of the causes of heart failure in our environment is due to hypertension. That's why it's important that we need to recognize hypertension early and also treat it early. Other important causes will be dilated cardiomyopathy, ischemic heart disease, peripartum cardiomyopathy, and then of course valvular heart disease, which seems to be going down in our environment. This is one of the local data, which I happen to be the principal investigator. This was at the University College Hospital in Ibadan, where if you look at the age, you find that we're having an average of about 52 years. So that tells you about where the peak of heart failure falls in the environment. It's not a disease of the elderly in the environment. Rather, you have the middle age afflicted by this condition. If you look at this data, the prevalence of heart failure across the world, what you will notice if you look at Africa is that it is stated that there are no population-based estimates. So much of what you find in Africa will be hospital-based studies, which would not really give you the true prevalence of heart failure. Looking at what are those things that will cause heart failure, I have a long list here. I will just highlight what is important. But what we should understand is that heart failure is actually the endpoint of any disease that affects the heart. And of course, there are also diseases outside the heart that may also affect the heart in such a way that it leads to heart failure. So diseases from the disease of the covering of the heart, which we call pericardium, so pericardial diseases. Diseases of the muscle of the heart, which we call myocardial diseases. Diseases of the valve, which we call valvular heart disease. And then, of course, disease of the blood supply to the heart, which is called ischemic heart disease. And then, of course, the disease, any congenitally deformed heart is also prone to heart failure. There are also toxins that may lead to heart failure. So excessive alcohol consumption, and then, of course, some cancer medications would also be considered as a cancer medications will also cause heart failure. So the first I have on my list, I just run through the list, is coronary artery disease, in which you talk about diseases of the part of the heart. And then, of course, I've mentioned hypertension. Hypertension is a very important cause of heart failure in the environment. And that's simple to diagnose because every time you go to a hospital, you can always ask that your blood pressure will be taken. There are even home devices now, which are very common and are not so expensive, that individuals can buy and they can use to estimate their blood pressure. I've talked about valve disease. Of course, there are irregular beats of the heart, also can lead to heart failure. The cardiomyopathies, there are so many of them. And then, of course, I've mentioned congenitally abnormal heart. Of course, infections like viral infections, including HIV, and then some other diseases, infections may affect the myocardium. I'll talk about toxins, which include medications, which are anti-cancer medications, which some of them are immunotherapies, and they can also cause heart failure. We have infiltrating diseases like amyloid, sarcoid. What they do is they are diseases of deposits, which you have some of these inflammatory cells or organ cells infiltrating organs. And if the heart is infiltrated, it can also cause disease. It can lead to heart failure. Of course, when you have abnormalities of storage, like storage of iron, glycogen storage, or you have a cardiac disease for some reasons, sometimes the inner lining of the heart gets fibrosed. And then, of course, because they are fibrosed and poorly functional, that lead to heart failure. I'm talking about the covering of the heart, pericardial diseases, and then, of course, metabolic diseases. Those that have thyroid diseases, some nutritional diseases, and then, of course, some neuromuscular problems like Friedreich ataxia, muscular dystrophy. So the list is long, but then if you are going to hone down, we will say that hypertension is extremely important. Cardiomyopathies are important. There is ischemic heart disease. And then, of course, ulnar infection, you talk about rheumatic heart disease. Looking at the forms of heart failure, we talked about acute, which are talking about heart failure symptoms that develop within hours to days to few weeks. Whereas the chronic would be when you're talking about heart failure symptoms that have been there for months to years. We also talk about low output and high output heart failure. Most causes of heart failure will result in low output heart failure. But those that relate to thyroid toxicosis, for instance, when the thyroid gland is hyperfunctioning, will give a high output for heart failure, and then, of course, Paget's disease. The current concept now is more or less of systolic and diastolic heart failure, which is you are talking about whether you have abnormality of contractility, that is systole, or you have abnormality of relaxation. So there are some situations in which individuals develop symptoms of heart failure, and yet what they have, you find that the way they have contracts is still normal, or yes, it's still normal, sometimes very, very normal. So at that time, it might just be the relaxation of the heart that is a problem rather than the contraction. So we looked at the modified Framingham clinical criteria. So as I mentioned, that heart failure is a clinical syndrome. That means from the complaints of the individual that is affected and the evaluation of the patient, a lot of times we can make a firm diagnosis of heart failure. And most of these symptoms will relate to either because the heart is not functioning, you have fluids that are supposed to be mobilized that are not mobilized effectively. So they may flood the substance of the lungs, in which they keep pulmonary edema, or they may just be just around the heart, in which you have, around the lungs, in which you have pleural effusion. They may also accumulate in the legs, they may feed up the veins. So those are the issues, those are the things that revolve around the complaint. Of course, because the lungs are flooded, it results in shortness of breath or breathing difficulties in different circumstances. So if you look at the major criteria, if an individual has difficulty in lying down flat, so that if he lies flat, either with no pillow or one pillow, he has shortness of breath. That is autopnea. Of course, sometimes it may be that it's not as bad as that, so that the individual is able to lie down. And maybe some 1, 2, 3 hours into sleeping, he then wakes up feeling very, very short of breath or feeling as if he's drowning. And typically they have to sit up, sometimes go near a fan, go near a window. That is what we call paroxysmal nocturnal dyspnea, which we call PND. And then, of course, by the time they are evaluated, the doctor will find that they have veins that are congested. They have evidence that their lungs are congested, which we call pulmonary rales. They have a heart sound that is a reflection of the stress that the heart has been subject to, which we call the third heart sound. And of course, they have enlargement of the heart. Of course, if you then do a chest x-ray, you find that they have pulmonary edema on the chest x-ray. And then, of course, when you start giving them medications for heart failure, including water pills, you find that they lose significant amount of weight within 5 days. Those are major criteria. And if you have 2 of these major criteria, then you can make a diagnosis of heart failure. But if you find even just one, and you then find any of the 2 of these other ones that are classified as minor criteria, then you can make a firm diagnosis of heart failure. So somebody who has leg swelling, and of course for heart failure, to not be just one leg that is swollen. Because one leg, that will not be heart failure. It has to be 2 legs that are swollen. Then, of course, people cough at night, which is similar to what we call paroxysmal nocturnal dyspnea. In this case, the individuals will have paroxysms of cough at night and they have to sit up. As they lie down, the cough is worse. Of course, there is also the shortness of breath, which is usually progressive. That's what we call dyspnea or non-barrier exertion. It's progressive because it tends to start with mild exertion, with moderate exertion. So the individual may notice that he has the difficulty walking a long distance or climbing a height, like climbing stairs. That may be where it starts from. Of course, it tends to get worse and then it progresses to shortness of breath or mild exertion. If this is the point at which people come to hospital, they come to hospital either when they find that small things like combing the hair, taking their bath now becomes a problem. That's when they come to hospital. But ordinarily, one would expect that by the time they notice the shortness of breath, they should be able to present to their healthcare provider. Of course, when the doctor examines or does tests, we'll find that they have an enlargement of the liver, which is usually painful. We call it tender hepatomegaly. And of course, there may also be water in the lungs. And then heart rate, which is more than 120 beats per minute. Now, how is heart failure classified currently? It's classified into three. You have heart failure with reduced ejection fraction, which we call FREF, or heart failure with mildly reduced ejection fraction, HFM-REF, and then, of course, you have heart failure with preserved ejection fraction, which is called FPEF. So, the basis for this categorization is based on the ejection fraction. You know, and what is ejection fraction? Ejection fraction refers to the quantity of blood that the heart pumps with each heartbeat. Of course, you need your echocardiogram, that is the ultrasound of the heart, to be able to determine that. So what you do is that you look at the quantity of blood that the heart receives, that is in the heart when the heart is receiving blood. And then, of course, you calculate what is left after it's ejected the blood. The volume of that is ejected on what was there originally, the percentage constitutes the ejection fraction. And if it's less than 40%, that is heart failure will reduce ejection fraction. If it's between 41 to 49%, it's heart failure will mildly reduce ejection fraction. But if it's 50% or more, that is heart failure will preserve ejection fraction because it's assumed that heart failure, with ejection fraction from 50% and above, that is normal. Usually, if you have a patient with heart failure, you would evaluate them more. Maybe at intervals, maybe 6 months, 1 year, you continue to evaluate them and see how they are progressing with treatment. So sometimes they may need to be reclassified. So for instance, if you check 6 months down the line or 1 year down the line, and you find somebody who started off with ejection fraction less than 40%, and then by the time you're evaluating them, 6 months or 1 year down the line, they then have, if they remain at less than 40%, the diagnosis remains heart failure with reduced ejection fraction. But if they have improved beyond 40%, they are then classified as heart failure with improved ejection fraction. Those with mildly reduced ejection fraction, if they remain at this, if they deteriorate, they then classify them as heart failure with reduced ejection fraction. If they remain the same, they remain as heart failure with mildly reduced ejection fraction. And then, of course, if they improve to 50 or above, it then becomes heart failure with preserved ejection fraction. So that's how the classification goes. Now, still looking at how we make diagnosis, I mentioned before that heart failure is essentially a clinical syndrome. Of course, in modern times, the emphasis is also to be, to make the diagnosis as sure as possible. And there are some situations where it's really not clear whether the individual has more of a lung problem or extra cardiac issues, or they have multiple morbidities, multiple abnormalities. And at the time they are presenting with those symptoms, you are not sure which symptom is really responsible for what. So there are other ways of really trying to confirm that this diagnosis is very correct. One of them is to quickly do an ECG. Those with heart failure, more than 90% of times, their ECG will be abnormal. So if you find out a normal ECG, someone that you are diagnosing with heart failure, you will definitely need to review that diagnosis. So ECG has what we call a high negative predictive value, so that if your ECG is normal, we can almost say that the individual does not have heart failure. The other thing is also to assay for some neurohormones, which we call natriuretic peptides. I mentioned before that in heart failure, you have increase in wall stress. And so because of that increase, they produce some natriuretic peptides, which are ordinarily supposed to enhance excretion of water, but they are produced as a result of stress to the wall of the heart. So that is also used. And you have two of them that are commonly used. We call the BMP, which is brain natriuretic peptide, or the NT-proBNP, which is a N-terminal pro-brain natriuretic peptide. So the reference values are there. So the higher they are above those reference values, the more sure you are about the diagnosis. I also mentioned echocardiography, which I said is a heart ultrasound scan, which is very, very crucial, and you use to classify the heart failure type at this time. So I'll just go through some of those tests. X-ray is important because you can see fluid within the lungs and fluid just surrounding the lungs. You can also use it to look at the size of the heart, which is generally most of the time is large. And then, of course, you have evidence of water in the lungs, which we call pleural pericardial effusion. And the other important medical test I've talked about is the natriuretic peptides. When I talked about brain natriuretic peptides and the N-terminal pro-brain natriuretic peptides. This also has a high negative predictive value, so that if you are thinking of heart failure as an individual, you're not sure whether it's heart failure, but these values of your natriuretic peptides are normal. You can be sure that that individual does not have heart failure. I thought about ECG. ECG also has a high negative predictive value. If it's normal, then you are sure also that the individual does not have heart failure. Echocardiogram, I've talked about it. It's very important because it's considered to be the single most useful non-invasive assessment of left ventricular function, because you can use it to look at size, you can look at structure, whether you have congenital anomalies. You can look at function outside that, systolic and diastolic function. You can look at your valves. You can look at the way the walls of the heart are moving. You can see whether there are blood clots within the heart. And of course, there are several forms of echocardiogram. The typical one that is done is transthoracic echocardiogram, in which case the sonographer will just put the probe on top of the chest, and then he will look at it. Of course, there is also stress echo for those who are suspecting ischemic heart disease and the subvalvular heart disease. And of course, there is also transesophageal echo, which can be used for further evaluation. There are other tests that can be done. I won't bore you with this. We look at renal function, we look at thyroid function. I mentioned that because that can also affect the heart. So we can also check all this. Now, how do we classify heart failure? I'll talk about two classifications. There's a functional classification, and that's also a classification that is more related to how the patient should be managed. So this first one is what we call the New York Heart Association classification, in which case you have it between class 1 and class 4. Class 1 is when an individual who has a cardiac disease but has no limitation of physical activity. So you have this person who has a heart disease, and then he has no limitation at all. He can climb stairs, can walk fast, he can do whatever. The New York Heart Association class 2 are those patients with heart disease, but they have slight limitation of physical activity. So I mentioned that before. So you may find that there are people who, when they need to climb stairs, they have difficulties doing that. If they need to walk very fast or very far, then they have problems with that. That is New York Heart Association class 2. New York Heart Association class 3 refer to those who have marked limitation of exercise. So things that you consider ordinary day-to-day activity, they begin to have problem with that. You know, just coping within the house, like combing your hair, taking your bath, all those things then become like a big assignment. Then, of course, because they have shortness of breath when they do that. And then, of course, the final stage is where the individual have shortness of breath, even when they are not doing anything. Unfortunately, most people in Nigeria will come at that stage to class 3 or class 4, which are considered to be advanced stages, advanced classes of this of heart failure. Now, I talked about the second classification, which is talking about grades of heart failure. This is very useful because it helps us to be able to take measures, preventive measures and treatment to try and prevent overt heart failure. I will look into more details with that as we go on, but I'll just give a description or overview here that the grade A heart failure are those people who have risk factors for heart failure. You know, either they are hypertensive or they're diabetic or they have cholesterol abnormalities. But at this time, the heart structure and function is very normal, and they do not have any symptoms at all. They do not have shortness of breath. They don't, they don't have less swelling. They don't have any symptoms at all. And then we look at grade B, heart failure. Are those who have structural heart disease? Yes, at this time, it's either the heart is enlarged or the heart is dilated or it's not contracting as it should. But at this time, they don't have symptoms. This also offers opportunity for prevention. The grade C are those who have structural heart disease, and they either have current heart failure symptoms or they have had symptoms in the past. That is, of course, these ones, what you offer them is secondary prevention because they've had symptoms or they have current symptoms. And then grade D are advanced heart disease, which individuals will have symptoms of what we would call refractory symptoms. So in spite of treatment, they continue to have their symptoms. How does heart failure occur? So either because there is a structural abnormality or there is a functional abnormality, the heart is not able to contract the way it should, and that leads to stress, increased wall stress of the heart. And because of that, there is what we call Frank Starling mechanism that has to stretch the myocardium. They contract more, so they do more work. But at a stage, if nothing is done, this compensatory mechanism gets exhausted, and then that's when failure begins to take place. Also, while this is taking place, there is activation of biologically active neurohormones. And it is the understanding of this pathophysiology that has helped in the more current treatment of heart failure, because it is then known that particularly the two systems, sympathetic nervous system and the renin-angiotensin-aldosterone system comes into play, in which case they help to stimulate one the other, one pathway stimulates the other. And then, of course, they lead to vasoconstriction, they lead to retention of water. Most of those things, they lead to tachycardia. Initially, those things were thought to be just compensatory and harmless. Of course, it was understood later that they are actually harmful. And those are the factors that are responsible for the progression of heart failure. Of course, with time, you also, because of the response to those stress, you also find that the heart size and structure begins to change. This is more slowly developing, and we call it remodeling. So you begin to have a cardiac remodeling with or without cardiac dilatation. I've talked about this just quickly. And this summarizes what I've said, that when you have a poor ventricular function, the volume of blood, which is the stroke volume, is with the volume of blood that the heart pumps by beat reduces, the cardiac output reduces, and then of course you have the neurohormones. They are produced. And I mentioned that usually the more common, the main ones are the sympathetic nervous system and the renin-angiotensin aldosterone system. And at the end of the day, they lead to a lot of things: vasoconstriction, apoptosis, they lead to water retention and all that. Of course, what then happens is that you have further stress on the ventricular myocardium, you have more dilatation, and then you have a worsening of the heart failure. That's why the medications that are used currently are medications that are used to counteract all those neurocriminal mechanisms. So this just summarizing the tests as I mentioned them before, and then I'll go now to primary prevention. Seeing that heart failure is very common, and we understood how it comes about, we then need to talk about prevention. Because like they said, prevention is better than cure. So as mentioned before, the staging of heart failure, and I said that the staging also helps us in our preventive measures. So stage A and B, what you do for them are what we refer to as primary prevention. Because stage A heart failure talks about the people that have a heart that's at risk. So any individual, anybody who has hypertension, who has had stroke before, who has diabetes, who is obese, who is exposed to toxins, either they take a lot of alcohol or they take cancer chemotherapy, specific ones, or they have family history of cardiomyopathies or heart disease. This stage constitutes the heart at risk. So there has to be due diligence in looking at the risk factors that they have, and that has to be treated very aggressively. So for those who have family history or those who are exposed to toxins, there has to be regular follow-up of their heart function and their symptoms. For those in grade B or stage B, we're talking about those who already have structural abnormality, but they do not have heart failure symptoms. This kind of people will benefit from looking at blood tests to try and look at, is there evidence of stress on their heart? And even if that's not there, they then need to be on guideline or evidence-based medications that is known to improve heart function or to preserve heart function. So this is also still summarizing the same thing I mentioned. It's only just mentioning what should be the intervention. So for those with hypertension needs to be controlled. For those who have diabetes, as part of cardiovascular or cerebrovascular disease or high risk for cardiovascular disease, you then need to have what's called SGLT2 inhibitor, which is a medication that tends to preserve the natriuretic peptides. So of course it leads to passing losing more water, and is protective to the heart, is protective to the kidney. So those are some of the things we use for prevention of progression in them. For patients who then, of course, do have cardiovascular diseases, you need to manage their cardiovascular disease or their cerebrovascular disease. You need to manage that very aggressively. Those who are exposed to cardiotoxins, there has to be follow-up, regular evaluation, and then, of course, sometimes we may need to stop the medication. Sometimes we may need to get medication that will improve their heart function. And of course, those who are first-degree relatives or those with genetic diseases or inherited cardiomyopathies, they need to have counseling, they need to be screened, and sometimes that may include genetic screening. And for those with pre-heart failure, those who already have structural abnormalities, they need to be on medications. that have been proven to be helpful. The medications that counteract the renin-angiotensin system, which is ACE inhibitor, ARB, or ANI. And then, of course, they need to be on medications that counteract the sympathetic nervous system, which we refer to as a beta blocker. Now we talk about secondary prevention. For some, whatever you do, either because of ignorance or because it's a disease that tends to be progressive, they eventually develop heart failure. And at this stage, what you are talking about is secondary prevention. That is improving their quality of life, try to keep them as symptomatic as possible. So that is what you have. So for this group of patients, you have the same medications we talked about, the ACE inhibitor, the beta blocker, and of course you bring in the mineralocorticoid antagonists. Those are the medications that block water retention. And then I've talked about the SGLT2 inhibitor, dapagliflozin. And then, of course, usually they also get water pills or water medications for fluid retention. And then, of course, for some of them, if they do not then, they fulfill some criteria, they still benefit from further treatment. So if you find individuals who have very low ejection fraction and they have their QRS complexes on their ECG, that's what is representative of their ventricular systolic function, it's Y, which is a pointer to diffuse disease and uncoordinated contraction of the heart. These people, likely, they are prone to developing arrhythmias, dangerous arrhythmias. And so, if it is ischemic, maybe you know that it's a heart attack that led to their heart failure in the first place, those ones need to be on implantable defibrillator. These are devices that are implanted that provide shock when patients go into irregular heartbeat that will almost surely lead to loss of life if the shock is not provided. For those with non-ischemic causes, if they still have low ejection fraction, they should also have ICD. But the evidence is not as strong as when it is ischemic. That is when it's a heart attack that led to that. For those who also fulfill that criteria, and they now have a wide QRS complex. The first group I talked about are those with narrow complex. That means they are the ECG tracing. That tracing there that represents their ventricular activity is narrow. That means it's normal. It's close to normal or close to normal. Those should just get an ICD. But if you then find that they are wide, which is a pointer to the diffuse disease, and usually an uncoordinated contraction, they will also benefit from what we call a cardiac resynchronization therapy. That means inside that pacemaker that they have the ICD, they still need the ICD, but they then have a device that tries to re-coordinate the way the heart contracts, and that makes them feel better. Their symptoms improve, and they have a better quality of life. The other supportive treatment, which is part of secondary prevention, for individuals who have heart failure, you need to really educate the patient about the nature of the disease. Their family members also need to be educated, and also they need to be, there are some treatment that they may also do on their own before they even come to hospital. For instance, they're encouraged to monitor their weight, and if they are gaining weight unnecessarily, maybe over a day or 2 or 3, they may increase their diuretics before they come to hospital. Of course, they also need to talk about exercise because they still need to move. Everybody can walk, but it's just that the trekking or the walking they do will then have to be tailored, or whatever exercise they choose to do will be tailored to the symptoms that they have. So they must not do more than they can cope with. They also need to restrict fluid, and that should be to between 1.5 to 2 liters a day. And then, of course, they need to take only minimal salt as needed and not to take salt excessively. We also need to take measures to make sure their weight is normal. They are not overweight. Most patients with chronic heart failure tend to even lose weight anyway, but then they need to have a normal weight. There are immunizations that those with heart failure should take. The flu jab or the influenza vaccine, as we call it, and the pneumococcal vaccine, because If they have a respiratory infection, it will tip them to failure, as we also see as we look in this next few slides. Of course, those who drink alcohol a lot will either have to stop or reduce their alcohol consumption. And then, of course, we need to cancel them because sometimes those with chronic symptoms and the number of medications they need to take, it constitutes a psychological problem for them. So they also need psychotherapy and cancer. I've talked about heart failure with reduced ejection fraction, but then when we then look at those who have heart failure with mildly reduced ejection fraction, that those ones who reduce ejection fraction is between 41 and 49%. The medications that have been useful are the SGLT2 inhibitor, and then of course the water pills. Those ones have been found to be very, very useful. The other medications that the ones for the neurohormones that I mentioned before, the one for the renin-angiotensin system, the one for the beta blocker, the mineralocorticoid antagonist, and may be used, but they have not been shown to be as beneficial as the high heart failure or reduced ejection fraction. This slide is also showing the same thing. Now we go to the heart failure with preserved ejection fraction. That's talking about those people who have heart failure symptoms, but their heart is contracting normally. Of course, they also need to be treated. But here, the evidence is also similar for heart failure with mildly reduced ejection fraction. In fact, all the other three we talk about are found not to be very useful here. So they still need to go on their water pills, to go on their SGLT2 inhibitor. But the third cornerstone for treatment of those with preserved ejection fraction is to look at the other issues they have. The weight, you need to take care of their weight. The diabetes, you need to take care of that. There are other sclerotic disease, the obstructive sleep apnea. So in this, the emphasis is actually taking care of the comorbidities and then just controlling. If you have blood pressure, to control that appropriately. Yes, so this is just to look at what other options are available for treatment. We're gone as far as to say you can give implantable cardiovascular defibrillator, which we call ICD. But there are some people that will also benefit from some other things, because for some people that have failure, you may find that what they actually have is ischemic heart disease. That means the pipe taking blood to their heart is blocked or almost blocked, and you can do bypass surgery for them. Then, of course, for some people, when it's regular beats, like atrial fibrillation, you may be able to do ablation for them. And these are also people that may benefit from use of digoxin. For many of us, for those who are familiar with treatment of heart failure, they know that several years back, digoxin was a major medication that was being used, but it's now limited to those who are not responding to the initial treatment. The other things are those who have severe regurgitation. They can also have repair of the mitral valve if they have severe mitral regurgitation. And for those who still have heart rates more than 70 beats per minute, even though they are on beta blocker, yes, and they are symptomatic, they're still not completely okay, you can have the medication we call ibabradine, which reduces the heart rate even more. And in some studies, we found that those in this category who have not responded to the medications we mentioned earlier, a combination of adrenaline and azoxybate can also be used. Of course, we also not forget those that surgery can also be done for aortic valve stenosis, either a surgical replacement or a percutaneous trans-aortic valve implantation. So what about what can we also do? This is also preventing as part of secondary prevention, because most of the time, those who present with acute heart failure, that means short-term either worsening of symptoms, is usually due to something, either because they are not taking their medications or a new problem has developed. And that is why when we take measures to avoid block in the pipes taking blood to the heart, the regular heartbeat, where we make sure that blood pressure is always well controlled, And then, of course, along with their doctors, they have avoid as much as possible things that can be toxic to the heart, like non-steroidal anti-inflammatory drugs, which should be used cautiously. Recreational drugs like cocaine, heroin, and all these things, and of course, alcohol consumption. And then we also make sure we encourage the patients and we monitor them on adherence, and we prevent infections by immunization we talked about. And where anticoagulation is necessary, we give that to prevent pulmonary embolism. And then, of course, acute exacerbation of chronic obstructive airway disease is recognized quickly and treated promptly. So when they need to undergo surgery, proper preparation is made with a multi-specialty team, including cardiologists, the surgeons, the anesthesiologists, intensivists, the nurses, in which how they are going to be managed pre and post-op is already mapped out. They have a better chance, and then of course we recognize metabolic uremia on time and treat them, and also cardiovascular insults. And we recognize complications when they occur. We take care of the anemia, when they develop. Of course, we will be also be avoiding a recurrence or preventing acute decompensation of the heart failure. So in summary, we'll say that the prevention can be divided into lifestyle measures, which is to help to achieve and to sustain low cardiovascular risk. So when you do your routine health check and you treat your cholesterol level, you tackle your sugar, and you tackle all the other things, you are trying to treat what you have and try to maintain a state that gives you a low cardiovascular risk. Of course, we need to identify the heart at risk. We need to recognize the heart that is pre-heart failure and intervene effectively. And of course, we need to institute effective treatment and to ensure and encourage compliance with treatment. And then, of course, the role of routine health checks cannot be emphasized. Just to finish, is to just show us this slide so that we know why we need to work on prevention. This is a slide that is looking at the survival of heart failure compared with some of the cancers we are aware of. People are afraid of cancer. But then if you look at 3 years, you have more people surviving colon cancer, prostate cancer, and breast cancer than surviving heart failure. So that's why we need to prevent. And when there is treatment, we make sure there is compliance with treatment. Thank you for your attention.